What physical therapists need to know about shoulder instability. Yo, Kevin, what's going on?
Dan, how are you? How was Aruba? Just came back from
It was
vacation.
okay. Very similar to Maynard, Mass. I don't understand why people go down to Aruba so much from the Boston area.
Right, yeah. I think the best part of your trip was all the North Korea talk this week in the clinic with your documentaries on the plane.
Oh yeah, that was wonderful. North Korea is a wild place. I'm not going to get started on that because that would literally be horrible for the listeners. But if you're interested in North Korea, definitely check out some documentaries. It's a wild place.
Yeah, best
What do
watch on
we
the
have?
airplane, right?
What's that?
Best watched on the airplane.
Yes, best watched on an airplane. It's not bad. What do we have for a topic today, Kevin?
Yeah, so we're starting a little series on shoulder instability. So this first episode, we're talking about kind of what PTs need to know about shoulder instability and just some kind of background terminology. And I know when I was first learning about this, there's a lot of terms that are confusing, and there's different types of shoulder instability. So I thought it would be helpful to just orient people to the topic a little bit, and then some links to articles that they could check out as well, just to learn more.
Yeah, I agree with you. I think that when I was in PT school, and PT school, it's not meant to prepare you thoroughly for everything. It's supposed to be just like a very brief understanding of a lot of different topics. But when I started practicing, I think I didn't know enough about this topic. And I think I made some wrong decisions. I think you were talking previously in the episode of the rotator cuff, where you're like, I had this guy who built a whole chicken coop right after he had a rotator cuff repair. And I was like, kind of my fault. I wish I had educated him a little bit better. Right. Which at the end of the day, who knows, right? Is that really your fault? But I think for myself too, I've had a bunch of these, especially traumatic instability events with patients. And I think as physical therapists, we're almost always thinking, all right, let's try conservative care. Let's do our best. Sometimes that's not the best choice. And we'll talk about more about it in these next few podcasts. But I agree with you. I think this is going to be really illuminating. And if you don't get this right, you could potentially set your patient up to be in a bad spot long term, unfortunately.
Totally. Yeah. So just starting off, just some quick definitions. So, what do we mean when we talk about instability? With the shoulder, generally there's a soft tissue or a bony insult that causes the humeral head to either sublux or dislocate from the glenoid fossa. So, we think about the shoulder obviously as a very mobile joint. It can move in all planes of motion. The most mobile joint in the body, right? So with that, unfortunately, with all that mobility, we do lose a little bit of stability, and we're more predisposed to some of this instability. And with the shoulder, we can have either a subluxation or a dislocation. So with a subluxation, some of the sources I was looking at was kind of defining that as you'll get the head moving around in the socket, but it doesn't fully remove itself from the socket, and there isn't a forced putting it back into the socket and relocation with that. Versus dislocation, you have a full, the ball comes out of the socket, the humeral head comes out of the glenoid, and a lot of times with that, we do see some other pathology. So it's definitely a more serious type of instability, and something on our subjective exam we want to make sure that a lot of times a patient will say, well, my joint, if it was really loose, it kind of popped out. We just want to clarify, was that a subluxation or a dislocation? Because like we'll get into, with a dislocation, a lot of times there's other issues that happen other than just, perhaps a labral tear or something like that. There could be a bony involvement and or a rotator cuff involvement, and that's something that we want to know, and perhaps get that person in for imaging if necessary, especially if it's been multiple times dislocation. But I think, yeah, those are important things to have in mind when you're evaluating someone with generally instability.
Yeah, good stuff. And I think that's pretty much what I had read too. When folks have a subluxation, generally speaking, that ball may come fully out of the socket, but it's very quick, goes in and out, right? So patients will kind of feel like the shoulder slid out really quickly and it went right back in. Definitions I've seen for dislocation, ball comes completely out, and then you either have to have it reduced by going to the emergency room, sometimes under anesthesia, And, anecdotally, I think the longer it's been out, the worse it's an issue, right? More damage potentially happens for this ball staying out for longer and longer. Or you have to do some sort of maneuver yourself to get your shoulder back in, right? So when you watch like the movies and someone's shoulder pops out and they ram their shoulder into the tree 7 times, right, in order to get it back in again, that'd probably be considered a dislocation and not a subluxation, right?
Yeah. That's how I usually treat it in the clinic.
I always think it's funny. You watch one of those movies and someone dislocates their shoulder, and all they have to do is get the shoulder back in, and all of a sudden they're shooting guns again and they're good to go. It's like, come on, dude. Like that thing is going to feel terrible afterwards. To go along with the video today, I have a little gift for you. It's an evidence-based cheat sheet for shoulder instability. It's a 4-page PDF that goes over everything you need to know about shoulder instability. We go over prevalence, anatomy, joint arthrokinematics, risk factors, and different types of instability, causes of instability, whether or not your patient should undergo surgery or have conservative care like physical therapy, and finally, rehab implications for all the different types of instability. So if you're looking to get up to speed about shoulder instability in less than 10 minutes, then this PDF is for you. I'll leave a link in the show notes in the description. Go ahead and click on that and then download it and then get back to what you're learning about right now.
Um, so just a little bit about like the incidents, how frequently is this happening? So what I was reading, about 1 to 2% of the general population will experience shoulder instability. And we see the highest rates in younger folks, so generally between the ages of 16 and 20. And I think that could be for a few reasons that, we'll get to eventually. But I think these folks tend to have a different type of collagen. Was something I came across, is that I think it's like a type 3 collagen. It's a little more stretchy. And as we get older, that kind of changes. So it makes the shoulder a little more stable. And then also, I think these folks are doing a lot more activity, right? So a lot more like physical activity, playing sports, overhead sports, physical contact sports. That may account for some of the instability we see in that population. And then there were a couple interesting studies that I came across, and I think this kind of gives some value to what I was just saying in terms of whether it's a physical sport. Maybe in a younger age you have more higher rates of dislocation, because in this study looking at the US military, I'm thinking, that's not super, it's physical, but it's not contact. And what we see, and when they looked at this group of 4,000 students in the military, 2.8% incidence of instability in that group. And then they just tried to classify, what percentage of that is having a subluxation and what percentage is having a dislocation. So subluxations are way more common. This study found that to be about 85% of those instability events, versus 15 for dislocations. And then when we look at a contact sport, this rugby study I thought was pretty interesting. So they had 378 male high school athletes, and they found the instability incidence to be 15%. So a lot higher than in the military group and a lot higher than in the general population. So I think with these contact sports like football, rugby, hockey, we probably will see a higher incidence if you're working with those populations. And just anecdotally, like at Champion with the active populations we work with, I would say shoulder instability makes up a lot more than 1 to 2% of my caseload. It's, very high. And then I thought, on the point about dislocation versus subluxation, athletes with a previous history of dislocating entering this season where they were following the athletes through, 55% of them had a subsequent dislocation. So, I think that's a big deal. And kind of what you said in the intro, maybe if we have someone come in with a dislocation and we're not, paying attention so much to what the research might be telling us is best for the patient, and something I've definitely been guilty of, trying to just rehab them conservatively. But they may be at higher risk of dislocating again, especially if there was enough tissue damage and we weren't aware of that in the rehab process. So, I thought that was interesting, and something to, if you have someone come in with a dislocation who's playing a contact sport, unfortunately, there's a pretty high percentage chance that they could go ahead and have another dislocation, which, more instability, more tissue damage type thing.
Yeah, and that's kind of what I was speaking about previously. if an athlete has a shoulder dislocation and the first person they see is a surgeon, which happens a lot, and most of the studies that we read through, I'll leave a link in the show notes if you guys want to check out the references. They will actually recommend, even for first time dislocations, to get a bankart repair or some other sort of repair for the shoulder, even after they've had dislocation, haven't trialed physical therapy yet, right? We'll get into this in future shows, and this is part of your decision making. But when a patient comes in, that traumatic anterior instability event, there's a good chance it's going to happen again, especially if you're in a contact sport. So I think as physical therapists, we're always trying to do the conservative thing. But I think what we should probably doing is what's best for that patient. And they should know. I mean, I had a patient at one point who had two dislocations, was a rugby player, and really did not want to get surgery. And we kind of pushed him that way and rehabbed him. And we got really lucky. He came back and he didn't have another dislocation for the rest of the season. But I think you're playing with fire, right? And as Kevin said, not to steal his thunder, because I think he's going to talk about this a little bit later. If you have more concomitant pathologies, right, and this could be a rotator cuff tear, but the other thing could be is bony damage, particularly at the glenoid. So we talk about the ball and socket joint being unstable, like this golf ball on a tee, and that's true. It's not as congruent as, let's say, the hip, but once you start losing the glenoid, it becomes easier and easier to re-dislocate over the course of time. And the other piece is that if you dislocate your shoulder and tear your labrum, but you don't tear or don't injure any of the bone, you go back, you recur, and then you chunk off a piece of that glenoid, then you might be looking at a different surgery like a ladder J or something, just because you no longer have that bony congruency. So if you tell folks like, hey, you're fine, let's try conservative first, send them back, you might be putting them in a position where they get hurt again, right?
All right. So now if we're thinking about, we've gone over instability, dislocations, and subluxations. And now another way we can think about this to categorize people is it like a traumatic type thing? Is it a multi-directional type thing where they're loose, from the time they were born growing up, they're more loose than other folks. So a way that they've gone about categorizing this is using some different acronyms. First one is TUBS. So this stands for traumatic unilateral. Oftentimes there's a bankart lesion. And oftentimes, as Dan just alluded to, they'll opt for surgery. So they call these folks, they're torn loose. So they weren't loose to begin with. They had some type of traumatic accident and they ended up tearing. A lot of times it's accompanied with a bankart lesion. And unilateral kind of just speaks to, it's traumatic, it's happening on one side, unless you have kind of a freak accident where you injure both shoulders. Generally, with this type of presentation, that traumatic injury for instability, they're going to have anterior instability. And what we see there is usually the mechanism of injury is kind of that horizontal abduction, external rotation, a little bit of extension. So I could picture in sport, like if you're a football player and you're going to stiff arm someone and then someone, kind of hits your arm backwards, your arm kind of like fulcrums to the front and irritates the anterior capsule. And, with that, some of the different issues we see is a bankart tear. So that anterior labrum will kind of tear off the glenoid rim. You can have like an anterior capsule injury too to some of those ligaments. A hillsachs lesion. So, we'll get into this, but, if the humeral head comes out anteriorly, kind of on its way back in, the posterior superior part of that humeral head will chip off. And, I've seen some of the articles we were going through for this, that if a surgeon sees a certain percentage of bone loss on that humeral head, I believe some are over like 20% is what they consider definitely surgery. And then it can be a little gray if it's a lot less than that. It kind of depends on the surgeon and their specific wants and stuff like that. But, that's something to consider, is how much, if there was bone loss, how much. And it's common to have bone loss with this. And then a little less common with this type of presentation is a posterior instability. So that we're kind of thinking the opposite, maybe horizontal adduction, internal rotation, or flexion force that can tear the posterior capsule. And the posterior capsule is pretty thin, but I guess that we just don't do as many activities in those directions that cause our instability as we do in the other direction. And we can get similar issues with that. So we can get again, a bankart repair. It would be a reverse bankart, so kind of on the other side, a posterior capsule tear, or a reverse hillsachs. So same type of mechanism where that humeral head's going to dislocate posteriorly, and then on its way back in, the anterior medial part of the humeral head can sustain some bone loss. So again, that's going to be something that if you're unsure about, you probably want to refer for imaging and just get some baseline on how much bone loss these folks had, and let the surgeon and you and the patient come up with a plan for how to best attack that. And sometimes it will be surgical.
Yeah, good stuff. Um, I guess just to reiterate, I think generally speaking, if you're trying to figure out what type of instability someone is going to be dealing with, you can ask about that mechanism of injury. So, just like Kevin was saying, if you have anterior instability, which is around 95% of all cases, an external rotation, abduction. So, if someone's running past you and grabs your arm and tears your arm back, that makes sense. Probably having a tear anteriorly. The other one that happens sometimes is someone's arm goes into hyperextension, right? And maybe you fall on your arm in hyperextension. It kind of pops the ball forward in the socket. Those are definitely going to be most common. It's interesting. The body is probably smart, right? I'm assuming. But I would imagine that if 95% of all dislocations are going to be anterior, it makes sense that the anterior inferior capsule is nice and strong, right? Whereas the posterior, not so much. And I think, Kevin, do you have posterior instability or anterior? I don't remember.
It feels like posterior. Yeah.
Yeah,
So for me,
nice.
like that horizontal adduction, if you do like the posterior, posterior like fulcrum to my arm, feels very scary, feels terrible. But it's
Yeah.
interesting because I think about that mechanism, and it's back when I was doing CrossFit more, and I was doing a pull on the rings for like a muscle up. And I wonder if it was like the extreme force for using my posterior deltoid, to pull myself up, that it's, maybe it pulled my humeral head really far back. I definitely didn't have like the kipping technique down I needed on the rings. So it was probably 95% arms and 5% core.
Yeah. Yep. That does kind of speak to the mechanism of injury sometimes, right? So if you're hanging from, let's say, gymnastics rings, for guys who don't know what that is, just basically rings. Like if you watch the Olympics, they're doing gymnastics, they're doing the ring event, kipping, right? So basically, you're hanging full body weight, and that's pulling the ball up in the socket, and the body's pulling down. But those traction forces going on. And like you had said, if you forcefully engage, let's say the lats or some other musculature that pulls the ball backwards in the socket, right? And most folks that have posterior instability, they're going to have trouble with arm across body, internal rotation, and end range flexion because all those things challenge the posterior capsule. So if you're hanging in basically a pull up position and you're gauging a bunch of muscles that pull the ball posteriorly in the socket, when that posterior capsule is already being stretched, may cause some issues. I had a nice little posterior instability event. I've actually had a couple. I think I actually started in high school wrestling, just being on hands and knees, and someone kind of pushed me forward, land on my hand, and the ball kind of went posteriorly in the socket. And I've had, I want to say, 4 or 5 subluxations. And then I would say a little over a year ago, I think I had a true dislocation where it popped out for maybe 5 to 10 seconds. And I just flexed my shoulder, went right back in again. Um, and I've been really lucky with that. But that was an arm across the body mechanism, right? So I essentially had my arm across my body. I do Brazilian Jiu Jitsu, arms across my body. Someone was trying to control me by pulling my arm across my body. I wanted to pull it back out again. And kind of as you said, I think I pulled my own ball out of my socket, which is kind of a really interesting thing to think. But arm all the way across the body, stretching the posterior capsule out quite a bit. I'm aggressively firing the musculature in the back of my shoulder, try to get my arm back. And I just felt my ball just go back in the socket where it shouldn't go. Felt kind of a tearing sensation. Went back in pretty quickly. So I was lucky and I've been able to rehab it. So yeah, that mechanism of injury is going to be really important. In the subjective, you can often tease out the direction just by trying to figure out what was that mechanism, what was the position they were in, to try to theorize what's going on. And obviously you can lead up with objective tests and try to figure this out.
Totally. Is your shoulder back to like 100%, you feel like?
I feel like it's pretty close. I do
Yeah.
everything that I want to do. There's nothing I think about movement wise that I can't do. I will get a little sore in the back of my shoulder after doing certain things, but it's relatively minor, and it's just gotten better and better. So I think I've been pretty lucky. Um, we may note on some of the rehab stuff and whether or not you decide to go more conservative versus not a little bit later. But so far, I think I'm happy with my decision to
Yeah.
not get
Yeah. We'll talk
surgery.
about that. It'll be interesting. I think unsurprisingly, you did a crap ton of rehab for it. I think you're really good about that. When you have something going on, you practice what you preach. When you're in there like doing the craziest exercises to stress the posterior capsule and just hammering it for months. And yeah, that's awesome.
Sometimes.
Yeah.
That
All
is a
right.
big problem, though. We'll talk about some of these stats later, but dislocations are kind of like ankle sprains. People don't take them that seriously. They get back to sport really quickly, and there's a super high recurrence rate. So I'm curious if we did a better job, if things would be better. But just guessing, right?
Yeah, totally. I feel like especially subluxations, some people just think it's like their norm. It's a normal thing, and so that's kind of wild. But
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning.
We've talked about this a little bit. Just a quick note on the dislocation versus the subluxation. Again, when you're doing the subjective, you do want to try to tease this out because there's generally a lot more tissue damage with a shoulder dislocation. And then these were just some interesting statistics. So Owens was a kind of a big name. I can't remember his first name, but for going over some of the instability research, I think he's a medical doctor, not a PT, but he had a lot of good articles out there. So this one was looking, he was citing another article where they reviewed initial dislocations of 63 young athletes at the U.S. Military Academy, and they found in that group that 97% had a bankart tear, and 90% had a hillsachs. So a first-time dislocation, those very high rates of some pretty significant pathology. So it's not like it just pops out and now they're loose. There's some anatomical disruption there. And then in the same article, he also cites another paper where, we were talking about age a little bit earlier and how that influences instability. So he reported on 227 patients with a primary shoulder dislocation. So first time in the anterior direction. And if you're over the age of 30, these folks only had a recurrence rate. And I can't remember the time span in between, how long they were following these folks for. I'd have to look at the study. But if you're over the age of 30, only 27% had another recurrence of a dislocation. But if you're 23 or younger, so one of these younger folks, you had a 72% recurrence rate. So those statistics are pretty wild. It's like if you're 35 years old and you have a dislocation, I mean, there could be a significant amount of trauma. You'd want to get that, repaired probably, depending on the amount of anatomical damage. But, if it's kind of borderline, we might have a better chance rehabbing those folks just looking at this data versus if you're younger. And one of the statistics I came across, I think we'll talk about it in a future episode, but one study was citing if you were under the age of 10 years old and you have a dislocation, your future risk of dislocating was 100%. So, if you're really young, it's just like, it's going to happen again. So it's kind of crazy. And then when we don't manage this the right way and there is, recurrence over time of instability, it does seem to correlate to higher rates of osteoarthritis. And, this could be something that matters down the road. You might be young and think, whatever, I can deal with it doing this. But if you do educate those folks that they might need we might have higher rates of arthritis, and that could potentially lead to something like a shoulder replacement. That's not something that you want. I think shoulder replacements are still, pretty gnarly. I'd rather have like a hip or knee. Shoulder's kind of scary to me in terms of getting back all your function. So you don't want to scare the folks, but you do kind of want to educate them that, for your long-term shoulder health, perhaps it's better if you're only, 21 years old and you have a pretty significant dislocation to consult with a surgeon. So I thought these were some interesting statistics.
Yeah, I thought they were really interesting too. Of note, and you had kind of said this, I think that I don't know, two things. One, in the social media landscape, a lot of folks kind of say, all right, everyone has a tear. You have a tear, I have a tear. My labrum's torn, your labrum's torn. Why does it matter? In the case of anterior instability, obviously this matters quite a bit, right? So I think this is one of those cases where if you have a big old tear, big old bankart lesion, good chance that is going to be problematic and is potentially a great reason to get surgery, right? As we're chatting about. I think the other piece is that from a special test perspective, we're always looking for something that kind of has high sensitivity specificity. If you have an athlete and you're pretty sure they dislocated their shoulder, you can be almost certain they also have a bankart lesion as well, right? So it's one of those instances where it's pretty cut and dry. If someone has a major instability event, dislocation, they haven't seen a doctor yet, I'm going to be very cautious with the way I approach that shoulder. I don't know that I need to do a ton of special tests to provoke that joint. Last thing you want to do is have it dislocate again. You kind of know what's going on. So I don't know. Just be cautious when you approach these patients because they're going to be very scared. And then we kind of know what's going on just based on that subjective information. We probably don't have to push them too much objectively, right? The other one I thought was really interesting is this recurrence rate. And I tell this joke to my patients all the time. If they ever have like a dislocation or anything like that and they're older, it's like, this is like the only time where being older is better, right?
Yeah.
And Kevin also talked about this a little bit. We're not exactly sure why these recurrence rates are lower, but it probably has something to do with the type of collagen you lay down as you get older. So sometime after the age of, let's say, 30 or so, it even seems to be sooner than that, right? So even our 20s, it seems to be better than our teens, right? And then 30s, 40s, 50s, it all seems to improve with age, which is hilarious. We tend to be stiffer. We put more collagen down that's stiffer after we have an injury, which is nice. And then you don't see a lot of like 50-year-olds trying to get back to rugby, right? So I think the reason why you see these recurrence rates a lot lower is simply because what folks are trying to get back to is a lot less. And even for someone like myself, right? So I still do, something that has a decent amount of, let's say, contact, falling on that shoulder, with jiu-jitsu is kind of like a wrestling sport. I still take it way easier than I would have if I was 17 years old. If I was 17 years old, I wouldn't think about it whatsoever. I put so much thought into what I do now to make sure I don't hurt myself. So I think age is just one of those things that educates us, makes us a little bit wiser and smarter with the way we train. So I think because of that, we're maybe a little less likely to have a recurrence as well.
Yeah, awesome. So just kind of picking up. So we went over kind of those torn loose folks. Another presentation you'll see, or you'll see in the research, the way they categorize it is AMBRI. So this is someone who is born loose, more of your multi-directional instability type person. So that's atraumatic. There's no trauma, not a clear mechanism of injury. They tend to have multi-directional instability. So then you are thinking, this is someone, this could be a genetic type thing. They're loose in all directions when you do some joint play. Bilateral, which again makes sense. This is probably just their genetics and their anatomy a little bit. If there has been no significant dislocation or crazy types of subluxations, this is something we could probably go for conservative rehab. At least we definitely want to start there, and then we can consider if this isn't working. A lot of times surgeons will do a procedure where they do like a capsular shift to tighten up the capsule a little bit. So that's something that we'll get into in terms of rehab and how we approach that. But again, an unstable shoulder, but a different presentation from that traumatic type instability. And then another one that I feel like we see a lot at Champion, a lot with overhead athletes, is there isn't necessarily a type of trauma. It's not like they had a dislocation event or anything like that. They might not have been born loose, but maybe we see this with baseball players and gymnasts. And this is called AIOS, or acquired instability overuse syndrome. So perhaps when you have somebody who often is, we talked about that anterior capsule being pretty robust, the anterior inferior capsule. A lot of times in baseball players, we see when they're always back in external rotation throwing, sometimes if they've adopted a pretty aggressive, weighted ball program, or they're doing a lot of stretching on their own into external rotation, we can see some instability that they've acquired over time that they don't have on the other side. So I think these folks, we might also try to rehab them conservatively, unless they start getting some, more subluxation events or a dislocation event. They might be more prone to that after years and years of acquired instability. But another presentation you'll see is that AIOS type presentation.
Yeah, for sure. A couple things to think about. So generally with the born loose folks, these are the folks that tend to do a little better with PT. And we'll kind of talk about this a little bit later. But if someone has that, frank instability dislocation, you're thinking, all right, we need some imaging, and then we could consider doing some conservative physical therapy. We have to be really careful with that. The folks that have the multi-direction instability, they tend to do quite well with physical therapy. And they also may go on to get surgery, but I mean, it's not flipped, so it's not like you're thinking about doing surgery from the get-go. It's kind of more, let's treat this conservatively. And after a while, if things aren't going our way, we can think more about surgery. The other piece is for folks who have multi-direction instability. You will probably notice that they have a lot of range of motion, right? If you do some capsular testing, drawer testing, glides, just to get a feel of the capsule, you usually have a lot of motion, right? The other thing these folks have is called capsular redundancy. They just have a lot of capsule. So when you watch them bring their arms overhead, the shoulder blade doesn't move very much. Because if you think about it, 2/3 of the motion overhead is supposed to come from the glenohumeral joint, 1/3 from the scapula. These folks have so much motion at the shoulder joint, the scapula doesn't always go along for the ride. So you'll notice that when they do activities with their arms, particularly abduction or flexion. And the other piece is from a rehab perspective, and there's some papers on this, you can attempt to try to have the patient use their shoulder blade a little bit more. So we're not getting so much motion from the shoulder joint. We're getting a little bit more help from the scapula. Tends to be helpful for these folks. So a couple things you can do from a rehab perspective. The other piece I will say is that, we talk about this instability being a negative thing. In some ways, it may be a positive adaptation, which is funny because I don't know the stats. I'm not a huge baseball guy, but obviously I'm in a baseball facility. But for every degree of external rotation you get, you can add more velocity on your throw. So a lot of folks are trying to get more layback, right? And that may be beneficial to throw faster. But then what we'll see is that their total range of motion ends up getting bigger and they're just stretching that capsule most likely. So if folks are getting more and more flexible over the course of time, we just have to be careful with that because they might be overdoing it, right?
Yeah, it feels like, especially if you see the kids who are born loose and then they go ahead and try to add a bunch of external rotation, that's when they really see it seems like they really get into trouble. And like you said, their total arc changes, and you might see 15 or 20 degrees more total motion on that side that they've been working on motion wise. And it seems to come with a host of problems for them. So like you said, it seems like the best pitchers we see have a lot of motion. They just are perhaps born loose, or they've had that like acquired instability over time that made them a really good thrower. But it does come with risk.
Yeah. That's why Kevin and I are some of the best throwers of champion because we have
Ah,
so much
so
layback.
much layback. Yeah.
For you guys who don't get that joke, we work at Champion PT and Performance, and there's a bunch of guys with baseball backgrounds. And like, I think both of us played a little bit of baseball, but not a ton. And I kind of got hurt a few times in my shoulder, the throwing side. And I throw so horrible that I think that it's like they can't have me throw with patience just because like it tarnishes the reputation of Champion. It's that bad.
I know, geez, it is funny. Yeah, I think the last year I played was T-ball, so that was a competitive year. We almost had them in the championship game, but I retired after that. No more baseball for me.
Yeah. Dang.
Yep,
Dang.
yep. So hope that episode kind of orients people towards the different types of shoulder instability. We'll have more episodes coming up about shoulder instability, but I think a little background and understanding the nomenclature, so we're all kind of on the same page when we're talking about instability. Um, and it can help you kind of start to categorize this in your own patients in the clinic.
So now you know a little about shoulder instability. You still don't know the specifics about how to rehab folks with shoulder instability. In the next video, I'm going to leave a link in the corner. I want you to go ahead and click on that. I'm going to go over how to rehab a patient with multi-direction instability from can't do much because their shoulder is killing them all the way back up to high-level CrossFit. Go ahead and click on that link and I'll see you there. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.